Liz, do you want to start recording? Okay, perfect. Good morning, everyone. Welcome again to another edition of our CVM Grand Rounds. Today, we are delighted to welcome Dr. Basir, who's the director of the Acute Mechanical Circulatory Support Program at Henry Ford Hospital. He's going to talk to us about the contemporary management of cardiogenic shock. Dr. Basir is a graduate of the Lake Erie College of Osteopathic Medicine with a residency at Indiana University and then fellowship in cardiology and interventional cardiology, and also complex coronary interventions at Henry Ford Hospital. Dr. Basir is a renowned expert in complex coronary artery disease and the management of cardiogenic shock. Has published extensively on the clinical management of cardiogenic shock and is an educator and an investigator. And we're delighted to have him talk to us about cardiogenic shock today. Thank you.
Dr. Thank you so much for the kind invitation. It's really an amazing honor to be here. If people don't mind, I'm going to digress a little bit for just the first minute of the talk, which is to essentially say that my family's journey in the United States actually began by a picture that you see here with my grandfather, who immigrated originally from what was then India to London, where he went to law school at London University, and then came to Yale in 1956 to attend law school and did constitutional law. And in fact, my mother was born in Connecticut, despite being raised in Pakistan the rest of her life. And it was an amazing achievement for him. He went on to being the Supreme Court Justice and the Ombudsman for Pakistan. So I was super thrilled to get this invitation, and I let my family know that, almost 50 years later, that another member of his household was at least virtually with the Yale faculty today. So moving on, my disclosures for the talk, I'm going to be talking about a study that I helped conduct called the National Cardiogenic Shock Initiative. This is a study that gets industry funding from Abiomed and Chiesi. Abiomed, for those of you who don't know, is the company that makes Impella devices. So when you hear that, I do have a conflict as it relates to that. And then my personal conflicts are listed as below. I help with the MCS development for the companies that are listed there as well. I think clinical disclosure is also important when we're giving these talks. I think Yale fits very similarly to Henry Ford in that we're a quaternary care center. We do a lot of hemodynamic support devices, and we have really good multidisciplinary teams with surgery and advanced heart failure, cardiac intensivists. And so it's a similar mindset, but I give similar talks in community-based programs where the majority of cardiogenic shock actually presents, and it's important to know the differences, but hopefully we'll be able to talk from similar backgrounds as well. So the objectives of the talk today were to kind of describe why cardiogenic shock is so hard to treat, why it's hard to study, what the current evidence is for the therapies that we do have, and why I personally have the belief that the use of shock protocols and teams may lead to better outcomes, the data behind that, and why I think at least in 2021, going into 2022, this is the best way of treating patients in cardiogenic shock, and essentially how I would want my parents to be treated if, God forbid, that happened to them, and why I feel so passionate about this cause. So a couple of important basic points for all of us to be on the same page with is that with the advent of improvement in medical therapy and preventative measures, and so much of what has advanced over really the modern day of medicine, we've really achieved the ability to improve the quality and longevity of a lot of patients' lives who have cardiovascular disease, most specifically patients with prior myocardial infarctions or patients with heart failure and reduced ejection fraction. And there's no doubt that our medical therapy right now, particularly with the kind of 4 pillars of guideline-directed medical therapy and heart failure, are really allowing us to keep patients in a good quality of life for a longer period of time. But unfortunately, what that does lead to is that when patients do present with MIs or cardiogenic shock or bad heart failure, that they come in, sicker than usual. And so if you look back, since in the era of revascularization, so there was a large amount of cardiogenic shock before revascularization, but in the era of revascularization, over the last few years, there's actually been a growing incidence of cardiogenic shock, mostly as it relates to an aging population with more comorbidities. But within the past 2 decades, really our mortality has been stagnant. And there's different measures that you can look at. If you look at an AMI population, the mortality is closer to 50%. If you look at an all-comers registry, the mortality is closer to 30%. And the use of more contemporary hemodynamic support devices has been really relegated to tertiary care, academic centers, with essentially, a high percentage of those hospitals having LVAD and transplant programs. And so it's really not for all programs. And that's been really challenging in terms of how we treat cardiogenic shock. Now, there have been some up-to-date changes that have occurred that have kind of helped in certain aspects of cardiogenic shock care. Previously, cardiogenic shock was defined really under the umbrella of end-organ hypoperfusion, whether that manifested itself in clinical or laboratory findings, as well as this idea of hypotension. And rarely, the diagnosis was made with invasive hemodynamics. And essentially, that broad definition actually includes a lot of different subset of patients. And so when you look at prior studies and you look at it under the banner of cardiogenic shock, it's a really heterogeneous cohort of patients. So one of the advantages that has come recently is the idea of classifying shock by shock severity. And this has been spearheaded by the SCAI Cardiogenic Shock Working Group. And I'm really thrilled to be on the most recent working group to kind of help solidify this a little bit more from the original work. And it's a simple algorithm. It's very similar to the Killip class, but it is something that is easily reproducible and something that we can really use on a day-to-day practice. But I think where it becomes really, really important is actually when we're comparing registries and hopefully in the future randomized control trials, where we can really prospectively put patients into these shock classification systems to be able to really understand what the patient population is that is being treated, how severe their cardiogenic shock actually is. Now, shock severity is only one component of the decisions and the importance of shock classification. The other that I think is actually really, really important, and I hope that all of the fellows and the trainees really, really appreciate this, is that there are different shock phenotypes. And there's been a lot of different investigators who have contributed to this idea. I'm going to really focus in on just two major examples. And that's the example of patients who have chronic decompensated heart failure and patients who present acutely. In my example, I'll use an AMI. However, an acute myocarditis can actually present in a similar fashion. So the chronic patients are like Vince Wilfork. So I didn't put this in because I'm speaking to you at Yale. Vince was a favorite athlete of mine when I was growing up. And so, Vince has an ischemic cardiomyopathy. His EF is 20%. He's on some medical therapy. His blood pressure is 80 and his heart rate is 90/60. His output's 3.8. But he's lived this way for 5 years. And Venus, who's also a favorite athlete of mine, is a healthy person with no meds, normal blood pressure, and normal cardiac output. So what Vince has and what these chronic heart failure patients have that we can't overlook is they already have a compensatory physiology. And that compensatory physiology with neurohormonal changes has occurred for a number of years, whereas Venus has no compensatory physiology. And the acute patients that present actually don't have those changes, and so they may in fact have a more robust response when they have an event such as an acute myocardial infarction. And so if Vince skipped his medications or just his heart failure has progressed and he comes in decompensated, his cardiac output may drop to 3.3. His blood pressure, he may be hypotensive at 80/60. His lactate may be elevated, but regardless of all of that, the mortality is still less than 25. Now, that's not saying that that's good. Any disease with a mortality of around 20% is still extremely important for us to be really aggressive and treat early, but it's different than the acute patient who comes in with the similar hemodynamic profile, but without compensatory physiology, whose mortality is greater than 50%. And I give this as a simple example for hopefully people to relate with and not forget, but there's data upon data that essentially has shown this. And if you go through multiple registries, there's been now 16 validated studies or validation studies for the SCAI Shoc classification. And when you look at those data sets, what you notice is that mortality is always associated with SCAI Shoc stage, but within different phenotypes, there's different severities. And on the left-hand side of your screen is a German registry from an AMI cohort that shows classic shock with a mortality of 50%. And that's AMI cardiogenic shock, acute cardiogenic shock. And then what you see on the right-hand side is 10,000 patients from the Mayo registry. And you can see that they have a mortality rate that's around 15%. And that's because these patients essentially have more decompensated heart failure, and they're in the CICU and have a different patient population at that time. So, that's kind of a little bit of background about why, it's or how to be able to kind of talk about cardiogenic shock and the important changes that have occurred over the last couple of years. But I want to also really emphasize why it's so hard to enroll patients in studies, because what you're going to see me present is essentially a prospective registry. And I think it's really important to get a background. And one aspect of care that's really challenging is that it's really hard to enroll these patients in randomized control trials. Now, there's a belief among some of us that, hemodynamic support devices are really like a parachute. And, these patients really, it's really unethical to randomize them and things like that. I think anybody who thinks that way may not be really a purist when it comes to science. I think that there's enough equipoise here to be able to randomize these patients. These devices come with complications, bleeding, limb ischemia, and it really becomes important to really have the highest level of evidence when it relates to these support devices. But what I think is probably the more important point in this is that we have to have really systematic and organized change as it relates to the consent process in these very sick and critically ill patients. And our colleagues in Europe have a tremendous head start on us in doing randomized control trials. And so really the last large-scale randomized control trial done in the United States was the Shoc trial, which was done over 20 years ago. And the majority of trials that have been done in Europe. And the reason for that is, as you can see on this figure, that informed consent, based on the laws of each individual country, are much more lenient and allow for the ability to consent patients with a two-physician consent when they're unable to consent for themselves. And that means one treating physician and one study physician feel that that patient is eligible for a trial. And so the culprit Shoc trial, which revascularized patients based on a culprit-only approach, or the idea of treating, complete revascularization, including trying to treat CTOs, was in fact many a times not consented by the patient or their family, but by two physicians. And that's something that is not going to be acceptable within the United States medical legal system, at least as of right now. And there's ongoing talks with the FDA to try to be able to overcome a lot of this inertia as it relates to a waiver of consent process. And what that leads to is that over the last 20 years, we've had approximately 2,000 patients actually enrolled in a randomized control trial. That is, far, far less than any other, contemporary disease process or that we've been taking care of that affects as many people as it does. And Michael Magali, who's one of our fantastic CHIP fellows, published this manuscript that should be coming out in JACC in February that essentially looked at, 2,100 patients enrolled in randomized control trials, and then over 100,000 patients that were enrolled in large registries. And there are really significant differences between those groups. There's fewer comorbidities in those patients who are randomized. They were less sick. They had higher blood pressure, lower lactate levels. They got more revascularization, more hemodynamic support, and they had lower mortality. So it's going to be really, really important to do these trials to try to answer question by question, but it's also really important for us to really make sure that we understand who the patient population is that we're studying, and not kind of broadly sweep these findings across a multiple subset of patients, particularly when cardiogenic shock encompasses such a heterogeneous cohort of patients. So what data do we have right now? Well, early revascularization helps patients who present with AMI cardiogenic shock. Now, at the end of the day, I'm an interventional cardiologist. I'm going to be talking a little bit more about AMI shock as compared to other forms of shock. But I think a lot of the major principles that I'll be discussing after revascularization are still the same. And so, again, this trial was done over 20 years ago and was really the last positive trial that we've had in cardiogenic shock. What I get the privilege of doing on a day-to-day basis, and something that's been really important for me, is I get the ability to be mentored by Bill O'Neill, who is really at the forefront of revascularization and primary PCI for the past 20 years. And this is data that he shared with me when we first started looking at cardiogenic shock. And this was data when he was a junior attending at the University of Michigan. And essentially, he created a registry and looked at early revascularization with PCI versus no revascularization. And what you can see is that those who got revascularization had a mortality of around 50%, and those who were not treated with revascularization and got either TPA or balloon pump or just vasopressors alone had a mortality, a survival of around 20%. And so what's important here that I just want to emphasize is that this was done in 1987. And if you remember the slide that I just showed you, the shock trial, randomized control trial data came out in 1999. And so it takes time to be able to come up with an idea, to validate it amongst a certain cohort of patients, and then to really potentially test it, in the most stringent way that we want to as researchers and scientists. So what other options do we have outside of revascularization? Well, we have pharmacological approaches, and it's something that we do every single day, where we use vasopressors and inotropes to be able to augment cardiac function and afterload to be able to optimize our ability to perfuse the body. However, it's really important to understand that all of these medications can increase myocardial oxygen consumption. Now, in the chronic heart failure patients, this may be less significant, at least for a short duration of time. However, it is really, really important in the AMI cardiogenic shock patients, because again, they have acutely injured their myocardium, and there's a really, really a high likelihood of increasing infarct size and increasing this myocardial oxygen consumption with the use of these agents. And so we really have to ask ourselves, how much harm are we doing by, for example, the idea of leaving patients on vasopressors and inotropes for 3 or 4 or 5 days after a episode of a STEMI. Now, we really haven't had a lot of data as it relates to specifically with inotropes and vasopressins, but more recently we have had the DREAMY trial, which compared Milrinone and Dobutamine. It was a double-blinded, single-center study from Canada, and it essentially looked at mostly stages of SCAI Shock B and C, and it was all comers who presented to the ICU, and they found that there was no difference in in-hospital mortality. Now, the trial isn't going to change a lot of what our regular practice is, but I wanted to particularly share it with the group today because it was really, I think, a really pragmatic trial, and I think it takes a lot of, interesting and novel ideas, especially in cardiogenic shock, where it's so hard to do traditional trials to be able to get answers. And so this was a group who basically came together as fellows and residents and basically created this trial within their CCU environment. And they recruited patients for a couple of years. And it was a long process to get to this answer, but it was a really well done study with extremely little funding. And so, these kind of niche approaches to being able to try to get answers is really important. And I encourage anyone who has interest in cardiogenic shock care to really kind of think about doing studies outside of trying to get millions of dollars from the NIH or different companies. Now, one of the most vigorous areas that we've been looking at for improving outcomes in cardiogenic shock is as it relates to mechanical circulatory support devices. And I think it's really because physiologically we know that we have the capability of doing the work for the heart, which is essentially just a pump. And so we can create pumps to be able to augment or take over for the heart's function. And so this is an area of tremendous focus and a lot of technological advancements. So the intra-aortic balloon pump Shock 2 trial was conducted throughout Europe and essentially showed that intra-aortic balloon pump had no significant value in AMI cardiogenic shock. Now, this isn't too hard to believe because a balloon pump essentially augments cardiac output and gives about a ½ liter of support. So if you go back to the idea of venous in cardiogenic shock because of an acute AMI, if she's used to seeing 5 to 6 liters of cardiac output, and now she's seeing 3 liters of cardiac output, and now you add a balloon pump in and her cardiac output is 3.5, well, her brain, kidneys, and liver are still seeing a cardiac output deficit. And, that's probably not going to be enough to change her clinical outcome. But I'm not a balloon pump hater, and I want to make sure that everyone understands this because you get certain physicians and groups of people who feel as if, people have to use certain devices, and they make their talks really device specific. And I don't have that personality. The device I use the most at my institution, and then the institutional device that we use the most at Henry Ford, is a balloon pump. And that's because we do a lot of patients with decompensated heart failure being evaluated for LVAD and transplant. And so a balloon pump actually may have a really niche role here in these patients who are really sensitive to afterload reduction and can get really robust responses, demonstrated in this study that was done out of Colombia as super responders, where they get, cardiac output augmentation of over a liter. And again, if you go back to that idea of Vince being decompensated, well, Vince's normal cardiac output was 3.8, and he came in with a cardiac output of 3.3. Well, an adding of a balloon pump may be enough to actually get him back onto the Starling curve and essentially, with medical therapy, re-optimize his preload, afterload, and improve his perfusion. And this is going to be studied in a randomized controlled trial in a decompensated heart failure patient cohort. But it's really important to understand that a balloon pump still has, I think, a role as of right now, even though across Europe it's completely being abandoned, with German rates of balloon pump use, for example, being less than 10%. So we move on to then, another traditional device, which was ECMO. And ECMO is really a fantastic device because it provides very significant peripheral perfusion. It oxygenates. It's really easy to cannulate to the point that you can be in a museum in Paris and have a cardiac arrest and still be able to be cannulated with ECMO in the middle of the museum hall, has been done in Paris and other cities across the world. But it is important to remember that ECMO comes with, a significantly high risk of stroke, likely because of the retrograde blood flow, high rates of bleeding and vascular access and ischemic complications, which I think can get much better with the utilization of cath lab techniques. And then physiologically, though, I think it's really important for those of us in cardiology that when we're dealing with AMI and really bad heart failure with reduced ejection fraction, that there is a significant afterload that occurs. And, for those of you who are not in the cath lab, you can see this on this aortogram where you see the flow from the ECMO kind of competing against the native flow that comes out of the left ventricle. And this can lead to a lot of increase in myocardial oxygen consumption and left ventricular dilatation. And there are definitely ways to mitigate that for all of us who use a lot of ECMO do. And so this was a paper from Germany as well, looking at ECPella, ECMO and Impella versus ECMO alone, which found that even though Impella had more vascular access complications, that there was an associated improvement in mortality with the use of left ventricular unloading within this setting. Now, what we've been doing more at Henry Ford is we've been using actually lava ECMO, and lava ECMO is this. It requires the use of a fenestrated cannula that's put in transeptally, and it pulls blood from both the left atrium and the right atrium. And so it indirectly unloads both the left and the right ventricle. And so this is a way to mitigate the need for the Impella here. So you allow for LV unloading indirectly, but you allow for that with only one large bore access. And so hopefully it would mitigate the vascular access complications, which were noted in the prior study. And I really am enthusiastic that this is going to be a really, really easy way of treating patients, especially because we're doing so many more structural procedures and there's so many more people who are comfortable with a transeptal puncture. And so if you have a little bit of time, maybe not in an AMI setting, but in other settings, we have a little bit of time, you can actually cross the septum and get a cannula, and typically within 20 to 30 minutes. And then we have Impella devices, which essentially are really simple devices. They're pigtail catheters with a pump on them. And so from an interventional standpoint, it's really easy to put in. And then more importantly, from a physiological standpoint, they do all of the things that you would want, particularly in an AMI cardiogenic shock, where they decreases LVEDP, improves coronary perfusion, and essentially decreases myocardial oxygen consumption. Now, when we talk about devices and compare devices, this is kind of how you see them in review articles and chapters of books. But, I want to make sure that all of us understand the reality. And the reality is that it's not what appears in textbooks. These are really, really sick patients to take care of. They require a tremendous amount of effort from surgeons, interventional cardiologists, cardiac critical care, intensivists in general, heart failure. I mean, it's really a team sport. You're worrying about bleeding, vascular access complications, stroke, the ultimate end goal for these patients, alternative access. And it really can become challenging and daunting. And I spend, I would say, probably 70% of my time in community-based programs, helping them solidify their cardiogenic shock programs. And they don't have the bells and the whistles that we do. And I think it's important for centers like Yale and Henry Ford to really make sure that we do a lot of community outreach to the centers that refer into your hospitals, and to really make sure that they have the training and a backup to be able to place these devices, care for them for 24, 48 hours if needed, because with the bed situation and with COVID, I think we've all realized the importance of how difficult it is to transfer patients at certain times. And so this is, patients present in cardiogenic shock in the community, and we really, really have to do a better job of making sure that all of our hospitals can use hemodynamic support devices. And so where this comes all together is this kind of natural birth of what we've called the cardiogenic shock team. And this was a recent paper in JACC from this year, which essentially looked at patients from a large critical care registry, and hospitals were divided into hospital systems with shock teams and no shock teams, and then they were matched, and essentially those patients who presented in cardiogenic shock teams actually had better outcomes. They had more use of invasive hemodynamics, more advanced mechanical circulatory support devices, meaning other than a balloon pump, and they had less mortality, at least as it relates to within the CICU. And so this is really where cardiogenic shock teams and protocols that have gotten into play. Now, again, it's not the idea of just creating a shock team is not what's going to get better outcomes, right? We should all understand that. What's important is the principles behind the shock team and what it causes. And there's a couple of important points. This idea of picking up a phone, getting everybody on board, and talking about one patient and making decisions in a quick manner is really one of the most important aspects and ways of improving outcomes. And so Innova has shown this within their work that they've done, and they've been fantastic, demonstrating their shock team within their hospital system, where for every increment of 20 minutes, they found a worsening mortality. And then on the right-hand side of your screen is the FIT STEMI trial. And what's really important is that this compares outcomes in patients without shock and without out-of-hospital cardiac arrest, and then without shock, but with out-of-hospital cardiac arrest. And what you can see up on the very top is the patients with shock with no cardiac arrest. And you can see that they have the highest slope. And the reason for that is because, again, they don't get the attention. And these are patients who tend to present with a lot of comorbidities. So if you have somebody with STEMI, well, that STEMI is going to get everybody to move a lot quicker. If they have out-of-hospital cardiac arrest, that's going to get everybody to move a lot quicker. But when it's just shock alone, people tend to slow down. And so it's really, really important concept that a shock team can improve the identification and early treatment for these patients. The other thing that shock teams are more likely to do is use invasive hemodynamics. Now, we all know from the ESCAPE trial that the routine use of Swan-Ganz catheters did not help change outcomes in patients with decompensated heart failure. But all of us who treat heart failure understand why that's the case, which is that generally patients are either cold and wet. And so you're going to give them Lasix and you're going to improve their afterload. And that's going to be the treatment strategy for the vast majority of patients. Some will need a little bit of inotropes, some will need some nipride and afterload reduction, but that's the majority of treatment. And so it's hard to say why a pulmonary artery catheter will change that management. But when it comes to cardiogenic shock, particularly within the community, it becomes really important. Why? Because if you're treating cardiogenic shock with a univentricular support device like an Impella, well, you could be missing left-sided heart failure. If you put everybody on ECMO, well, then you may actually miss out on the idea that their pulmonary capillary wedge pressure has been increasing over 24 hours and they may benefit from LV unloading. But what's the most important aspect of a Swan-Ganz catheter is it gives objective measures that allow for better utilization of advanced heart failure therapies, including temporary support and other interventions. And this is really important because what it does is it takes away this idea that Dr. A thinks, oh, this guy isn't too sick, but he'll turn around, or Dr. B thinks, oh, you know what, this guy is a little bit sick, but you know what, he's not going to turn around. And so it allows for objective measures to help make those decisions. Now, putting all of this together, and about 5 years ago, we started the Cardiogenic Shock Initiative, and it was a prospective, non-randomized, single-arm, multi-center trial, and we looked at patients with acute myocardial infarction and cardiogenic shock, and we used the same inclusion and exclusion criteria as prior randomized control trials, and we included about 400 patients that were included within this study. And just to be very clear, these were patients with really bad shock. These were patients who would be SCAI shock C, D, and E. This is not pre-shock or at-risk shock patients. It included 25% of patients who had stage E shock, and that was defined by active CPR at the time of support implantation, a lactate greater than 10 with pre-procedural cardiac arrest, or a lactate greater than 5 to 10 on multiple high-dose vasopressors and inotropes. So this was the patient who was either getting boluses of epinephrine on their way into the cath lab, or was on 50, 60 of Levophed as they were coming in, and also had pre-procedural cardiac arrest. So really, really sick patients. And again, we had hospital systems that were community-based, as the majority of hospitals within the shock initiative, because that's where cardiogenic shock originally presents. And with that, we created a really simple protocol. This is not rocket science, and for you and me and for a lot of people, this is pretty basic, but it really helped organize a lot of healthcare systems. And so it centers around rapid identification of cardiogenic shock, activating the cath lab. Again, we're talking about AMI shock. So getting femoral access, confirming the AMI and cardiogenic shock, and that can be with the left heart cath, right heart cath, echo. It really depends on the patient. So if you have a 50-year-old with an anterior STEMI and is on 20 of Levophed, your diagnosis is made. You may have an elderly patient where you need a little bit more information to make sure that it's all cardiogenic and not secondary to something else. And then you go ahead and you put in your support device, and you try to do that with a door to support time less than 90 minutes. Then you go on to revascularizing the patient, and then you put in a Swan-Ganz catheter. Now, I'll be honest with you, I look at so many different parameters with my right heart cath to be able to help make decisions. But really, that was not realistic within the majority of places that the Shock Initiative originally started. And we came up with two guiding principles. One was cardiac power output, which was one of the most sensitive and specific markers of outcomes in the original shock trial. And then this idea of pulmonary artery pulsatility index, which was a surrogate for right ventricular function. And so patients with normal CPOs and PAPIs, they were going to do fine. So you continue them to wean their vasopressors and inotropes. And then those patients with low cardiac power output, you help decide, Is this because I haven't treated RV failure? Is it because they're 6'2" and a big guy like myself and they need more support? What's the reason for their continued cardiogenic shock? And I think this is really the most important aspect of the care, which is that it gives people a playbook to help kind of make next decisions. And with that, we had tremendously good outcomes. So patients who were in stage C and D shock, what you would have seen in prior randomized control trials, they actually had 30-day survival rates of 77%. If you look at all comers and you add the 25% of patients who had stage E shock, their 30-day survival was 68%, higher than any of the previously published randomized control trials. And as I told you earlier, it's randomized control trials, in fact, include a typically less sick population that has higher survival rates. And so this was something that really is eye-opening and at least signals to us that this is probably a reasonable way of treating patients. Now, I don't want anyone to not, to say that I'm not being honest here. This is comparing different eras of medical therapy, different patient populations between Europe and the United States. Clearly, there are holes within this study so far, but I think what it does is it gives us a treatment pathway that we can now study in a randomized controlled trial and feel as if we can actually be able to find an answer or not. And when we compare NCSI to the other trials, it really is a very sick cohort of patients. Our average lactate was 4.8. 77% of patients had a lactate greater than 2. The blood pressure was lower than any other cohort of patients. And again, there was a lot of patients from Detroit within the NCSI, and we really take care of patients that are really underserved and have a lot of comorbidities as well. So it really, really is a very sick cohort of patients. So I wanted to kind of end my talk with a couple of things that I think are really important going forward. So one is that particularly when putting in univentricular left-sided support devices, it's really important for us to appreciate as a community, particularly the interventional community, because I think we lag behind in this, is the identification and the importance of right ventricular failure. So we looked at this within the first half of the cohort, and we found that patients with right ventricular failure had an absolute mortality of 14% that was higher as compared to those who had no right ventricular dysfunction. And so I think patients who are not doing well may benefit from right ventricular hemodynamic support device. Now, whether that means putting them on an Impella or a LAVA or just adding a right-sided support device, that's really based on your own team's local practice. But I think in certain patients, it can be helpful. The other aspect of things is that there is going to be a small percentage of patients, less than 20%, who continue to do very poorly despite an Impella and early revascularization. And these patients are the ones who are probably to get the most benefit of early escalation. And here we're talking about, for example, again, adding right-sided hemodynamic support device or an ECMO to really be able to give them complete hemodynamic support device. And I think that potentially has the option of improving outcomes. And we're going to be looking at this in a sub-study called the Ceramics trial, which is essentially, can early escalation improve outcomes in AMI cardiogenic shock? And we're going to study it very similarly to the way that we did in NCSI. The other aspect that's really important is that unfortunately these patients continue to suffer the consequences of heart failure and continue to have a high mortality within the first year. And I think it really sets up nicely this idea of within our heart failure clinics, developing cardiogenic shock clinics and really making sure that we optimize guideline-directed medical therapy for heart failure as much as possible, and potentially consider these patients for advanced therapies when we know they're not having a good recovery or they're still struggling to be placed on guideline-directed medical therapy. And the data is supported by this. When you look at, for example, VADs, which again don't have the limits of transplant as much. They were just as effective in patients with an AMI who presented in cardiogenic shock as compared to chronic longstanding heart failure patients. And so I think that this is really an important tool that's underutilized and underdiscussed, maybe not at centers like Yale and Henry Ford, but definitely within the community, that if we can get these patients to LVAD and transplant centers and evaluate them for LVAD, that we have the potential of saving lives as well. The last thing that I wanted to mention was that just because we have all of these technological advancements and tools, it's still critically important for us to do this quickly. If you look at shock stage at 24 hours after presenting from an AMI cardiogenic shock, those patients who are still struggling, who are still in stage E shock on multiple high-dose vasopressors, for example, despite being placed on hemodynamic support, escalating their support once end organs are affected is almost futile. And so it's really important that we have to do this early and not waste our resources, manpower, nursing power, physician power on patients when we know that they're not going to get good outcomes of care. And that's why it's important to have palliative care, hospice, all involved with the cardiogenic shock team. And so if you take a step back from everything that I've talked about today, and you forget everything that I mentioned, I hope that you just remember this slide, which is that any patient that comes in cardiogenic shock needs two things. You have to decide what the patient needs. Do they have a hemodynamic deficit? Is it univentricular, biventricular, and what's their therapeutic goal? Is there an out with LVAD and transplant? And what are my capabilities technologically? What's the complication risk if I put in a device? What's my own experience as an operator putting in a device, using alternative access, making sure the limbs don't get ischemic? And what's the institutional experience? So one interventionalist in hospital X cannot put in support devices and expect to change outcomes. They have to have a team to be able to take care of these patients. They have to have systems. They have to have more than one person doing it. And so it's something that I've emphasized as I've been speaking on this topic for the last few years, but it's really, really important to emphasize that as well. It's also important to emphasize that we have not been equal in our use of these advanced therapies. And if you look at hemodynamic support use, women all across the board get less revascularization, less invasive hemodynamics, less hemodynamic support, and it correlates with more mortality. And within ethnic minorities, we also tend to have the same outcomes. And so as we move forward, we need to make sure that we have equipoise in the delivery of this care. And I think shock protocols and teams help with that, because you essentially get the same phone call on the same patients to try to be able to help make your decisions. There's a lot of upcoming trials in cardiogenic shock, so these are listed for you. I hope that many of you pursue this as your research interest and something that you're passionate about, because I think there's a lot of work to be done. So to conclude my talk, NCSI is the largest prospective AMI cardiogenic shock study that's been done in the past 2 decades. It recruited a really sick cohort of patients, including 25% who were in stage E shock and are unlikely to be recruited into other trials. The outcomes in stage C to D shock were really impressive at 77% survival at 30 days. I think when we use better definitions for escalation, potentially more use of right ventricular support in the small subset of patients who need it, we'll be able to consistently get survival rates greater than 80%. Regardless, we still have heart failure problems for these patients. We have to optimize guideline-directed medical therapy, have them be evaluated in heart failure clinics. And again, there's a host of trials that are going to be done to help solidify a lot of the topics that I've discussed with you today. So thank you so much for the attention. I hope that I've left enough time in these last 10 minutes to answer your questions. But thank you so much. I will stop sharing my screen here.
Thank you so much, Dr. Basir. This is Oyeri Onuma. I'm one of the co-hosts of our Grand Round series. Thank you so much. I think that this is such an important topic, and having you summarize the pertinent points, important studies, and things that we should be keeping in mind is a really helpful contribution. I have some questions in the chat. Actually, I had one from Samit Shah. Samit, can I have you unmute and ask your question, please? And for others, you can raise your hands or type your questions in the chat function. Thank you.
Thanks so much for that incredible talk and the overview on a really complex topic. My question was just about exclusion from both NCSI and just in general with shock patients. Are there age cutoffs or specific medical diagnoses such as advanced cancer that should give us pause in the acute setting to stop and not offer mechanical circulatory support or advanced therapies?
Yeah, that's a great question. I think there's two approaches to it. I typically, one is to just use the idea of what is acceptable for LVAD and transplant. So, every hospital is different, but we tend to have, it's not a true cutoff, but I tend to have a cutoff around 70 years old within our institution. And then there are some guidelines as they relate to obesity, smoking history, drug use, as it relates to LVAD and transplant. When it comes to temporary support, I say that, the vast majority of people, we're still trying to essentially get them to recover. And I think when your goal is recovery, that just essentially means that you have to evaluate patients individually for how successful that's going to be. Definitely as you get older, across SCAI shock severity, age is an independent predictor of worse outcomes. And so the older patients, you definitely should take pause in that. But age is just one aspect of things. I can show you data where patients who are 80 years old and got support devices put in for cardiogenic shock had a survival rate of around 50%, which you could argue is actually really not that bad. Now, how do we leave them and in what condition we do, that goes a long way. I definitely think people with terminal cancers and mortality that was, or life expectancy, that's less than 1 year, are patients that are likely do not benefit from early hemodynamic support. But I always say that futility is something that it's hard to define, but when you see it, it's there. And so I'm very confident that the majority of reasonable clinicians, when they see some patient that they feel in their gut will not benefit, that those patients really shouldn't be treated. We should have a high threshold of using support devices.
Thank you so much. Dr. Cohen?
Thank you very much for a wonderfully comprehensive talk. My question is, in a community hospital, not Henry Ford or a high-powered hospital, but in a community hospital with limited resources, would you feel that an intra-aortic balloon pump is still the most reasonable intervention in that it will unload the left ventricle upon the beginning of systole, and it will perfuse the coronaries at the beginning of diastole, and it's relatively easy to insert? But I'd be very eager to hear your thoughts about that in a low-powered community hospital.
It's a fantastic question. I agree that in a low-powered community hospital, a use of a balloon pump is probably most ideally suited, with an early transfer to a larger hospital should escalation need to occur. And the problem is that we have almost zero data to back that statement, though. So just to be absolutely transparent and honest. So we know that a balloon pump is really just not enough for the vast majority of patients. But if there is an exit strategy available, meaning to say a patient would get transferred and subsequently escalated on an as needed basis, then I think that the help of that half a liter of support, which I typically equate to physicians as one inotrope, is more advantageous than not using that support. So yes.
Thank you.
I am impressed recently that that I think larger community-based programs, though, do have really a good acumen for using more robust support devices. And depending on the hub and spoke model, there's been tremendous success stories where devices are implanted within the community and sent to a hub center for further care and adjustment of devices and Swan-Ganz catheter placement and things like that. And so there's definitely opportunities for larger community-based programs to use more robust support devices.
Excellent. Well, if there are no other questions, Dr. Basir, I want to thank you again for spending the morning with us. Thank you again, and hopefully in future we can actually have you here in person in New Haven. Thanks everyone, and we'll see you again next week for Cardiovascular Grand Rounds. Thank you.
Thank you.